All right, good evening, everyone, and welcome to our spine panel webinar. This is our first webinar of 2025, and we are very lucky to have Dr. Weaver, Dr. Lee-Sigler, and Dr. Schroerlucke with us tonight and available to answer any questions you have. I'm going to encourage the audience to submit your questions in the chat. Some of the questions might be a little too case by case or specific for our doctors to answer on air. But you're more than welcome to email osmarketing@orthosouth.org, and we'll see if we can get answers for you. To begin, I'm going to let Dr. Schroerlucke give a brief introduction to the OrthoSouth Spine Institute.
Well, first of all, thank you guys all for being here. I want to thank my partners, Dr. Weaver and Dr. Sigler. I appreciate you guys being a part of this as well. I've been in Memphis for about 15 years practicing orthopedic surgery, specifically spine surgery, and we have a lot of great spine surgeons in town, but we've all been spread out. And for quite a while now, I've kind of thought it would be pretty great if we were all in one place where patients didn't have the confusing aspect of where to go when their back hurts or their neck hurts or they have pain running down their arms or pain running down their legs. Do they see a chiropractor? Do they see a physical therapist? Do they go to their internal medicine doctor? If they do need to see a doctor, do they see a physiatrist, pain management? Do they see a neurosurgeon? Do they see an orthopedic surgeon? And then if they do need surgery, are they seeing the surgeon that is the right one for them? And I think that we have a place now where you can go to one place and you know that you're going to get the best care. You know, since now that we've had incredible physiatrists and orthopedic spine surgeons in our practice, but now that we have 2 neurosurgeons in our practice and recently hired another orthopedic spine surgeon, it just completes the whole aspect of what spine surgery, what spine care in general can accomplish. And so if a patient comes and has a problem, they know that we're going to be able to handle whatever it is, whether it's a specific type of spine physical therapy that we need. We have spine specific physical therapists. If we need some type of an injection or some type of other option, we have spine specific people to do that. If we need neurosurgeon or orthopedic spine surgeon, you know, we collaborate, you know, almost daily with different patients. I mean, just today I sent a patient, Dr. Weaver, I sent a patient, Dr. Jardinus, to get their opinion. I talked to Dr. Sigler about a patient today, you know, so, you know, we're constantly working together, trying to get our patients the best care possible. And I think now that we're all one place with all these options, all working together, you know, the patients in Memphis they know that they're going to get the best care possible at the OrthoSouth Spine Institute. And I'm really, really excited what we've accomplished already in the short time that we've been together. And I think it's just going to get better and better for everyone.
Thank you, sir. All right, so we're going to start off with this quick introductory question, and we already have a few questions from our audience, so thank y'all for submitting those. Dr. Schroerlucke, I know you briefly introduced yourself, but Dr. Lee-Sigler and Dr. Weaver, would y'all introduce yourself and kind of explain your role on the spine team?
Okay, well, I'm Judith Lee-Sigler. I'm a physiatrist. I've been practicing medicine for over 30 years, spine medicine for over 30 years. And I've worked in a spine institute before in Central Illinois, and it was really a fantastic thing for the patients. Really, really made a great difference in their care. I do a comprehensive spine evaluation, well-versed in physical therapy techniques, lots of types of injections, other procedures that are not injections, but that are more advanced procedures. And I'm extremely excited to be part of this group, and I think it's going to lend a great deal of advantage to the patients in this area.
Yeah, I'll echo that sentiment. My name is Jason Weaver. I'm a neurosurgeon. I recently joined OrthoSouth about 5 months ago. I've also been in practice about almost 20 years now. I've been in Memphis my entire career. I did a special fellowship training in spinal oncology with big reconstructive spine tumor surgery, but I also have a special interest in minimally invasive and outpatient spine surgery, and that's sort of where my career has developed maybe in the last decade or so. I'll echo what has been said. I'm very excited to be under the umbrella of a spine institute where our focus is not some afterthought. It's the sole focus of providing comprehensive spine care from the conservative all the way up to the most complex of spinal surgeries. And we've got the best of orthopedics and neurosurgery, and we have all the tools that at our disposal to take care of the patient, whether it's the simple things, physical therapy, injection therapy, all the way up to the most complex and advanced newer techniques too. So I'm excited to hear what the questions are, and maybe we can delve into some of those issues tonight.
All right, one of our first questions from the audience is, who would a prospective spine patient see first on the team?
You want to talk, Judy? You want to take this one, Judy?
Yeah, I think it depends to some degree on what the problem is. So if the person has back pain going down their leg, very commonly they would start out seeing one of the physiatrists. If a person, if it's someone who has a fracture, they know they have a fracture, then they would probably see one of the surgeons. If they're having loss of bowel or bladder function and just really advanced weakness, that sort of thing, they would start out seeing one of the surgeons. I think that we have a really good triage team to kind of help the patient when they call, wade through the questions to know how to best direct them. And I've been finding that that's generally been the case.
Yeah, I
I
also
agree.
think, go ahead. Yeah, sorry.
I agree. And the bottom line is, I think as long as we can get the patient seen expeditiously at their convenience and not make them jump through a bunch of hoops and hurdles, that's one of the things I value about OrthoSouth and the way that they've set up the ease of access and convenience, because we've got multiple locations. We can see patients sometimes same day, certainly the next day, and just getting them into a provider. We as a team talk about these things ad nauseum, is that we're going to get them to the right provider. If they don't need a surgeon and they need conservative care, well, let's get them to Dr. Siegler. And Dr. Siegler, in the same vein, says, oh, this really needs to see a surgeon. We're available, like Dr. Schroerlucke said, we're constantly talking to each other on the phone. We can get that patient seen in clinic that day, that afternoon, next day. So we just want to get people in the door and get them taken care of, get their life back in order.
All righty, next question. I think this is a good one for each of you to answer. What are some of the most common spine conditions you see?
I'll go first. I mean, look, I think the most common spine condition I see still is regular old back pain. And I say regular old back pain because it is so prevalent in our society, as humans, as as we get older, as we stay active, people have back pain. And back pain could be from the muscles in the back, it could be from the joints, it could be from the discs, it could be from the nerves. There's so many different things that could cause it, but that is the most common thing that I see. And honestly, it's really complicated, and it seems really simple. You got back pain. Well, it's complicated to get it better. It's complicated to treat it with physical therapy. It's complicated to treat it with medications, and it's complicated to treat it with any other procedures. But that is definitely the most common thing I see. I bet you Dr. Siegler and Dr. Lee would say the same thing, but maybe they won't. But that's the most common thing, and I think that it is difficult for patients to know where to go when they have back pain for those reasons. That it is seemingly simple, but it's actually complicated.
Yeah, and I think the other thing is that sometimes a person thinks it's coming from their hip and it's actually their back, or they think that it's coming from their shoulder and it's actually their neck. So I think that although back pain, neck pain, those are extremely common. The other things that are extremely common is they're not really sure. I thought it was this, but now I don't really know. And I think that's really the most common thing. And it's challenging, but it's something that we train to do, know how to talk to each other, know the tests to do, and that's what makes it good for the patient.
Okay. All right, next question. How do your approaches differ when treating spine conditions, and how do you collaborate with other specialists to provide comprehensive care? Dr. Schroerlucke, I know you already touched on this a little bit, but maybe you could go a little deeper in detail this time.
Yeah, ask that question one more time, Savannah, please.
How do your approaches differ when treating spine conditions, and how do you collaborate with other specialists to provide comprehensive care?
Yeah, I mean, look, this is very patient specific, and it is hard to get into the weeds with this type of things. But yeah, if we, you know, we each have we've each been trained a little differently. We each have our own skill set that have been developed over the last several decades. We each have our own, you know, preferences on the type of things that we like to do, the things that we do more often. And when we know that about each other, we're able to get the patient to where they need to go. And so, you know, I've seen Dr. Sigler work long enough. We've talked long enough. I know the things that she likes to do. I know the things that she's really good at. Same with Dr. Weaver and all of our other providers. We all know each other well enough at this point. Yes, if it's something that Dr. Weaver handles much more often than I do, and he has a specifically trained for it, then I send patients to him to take care of that, you know, and vice versa.
Yeah, I'll even take it one step further. One thing that we've implemented is a case conference series that sometimes is open widely across the whole institute, and sometimes it's very doctor specific. And we share difficult cases with each other and bounce ideas off of each other. And so that's one of the big benefits of having a specific spine institute, where we get to know each other's practices a little bit better. It's not just passing each other in the hallway, but it's actually delving into the specifics of tough cases, so to speak.
Yeah, I think that's really probably the special thing, is that you're not waiting necessarily for somebody to call you back the next day or somebody's notes. We share our medical records. So I can look and see what Dr. Weaver's done, what Dr. Schroerlucke's done, what the other spine doctors have done. And if I have a question, I can ask them then, and I'm not waiting 1 or 2 or 3 or 4 days for records to come through, or, you know, call me back in a couple of days. That communication is instantaneous almost. And then we can get back to the patient with regard to what the opinion is. And that helps kind of combine opinions, and a person feels more, one, better cared for, and 2, knows that there's a collaborative effort towards their betterment.
Can you share your perspective on the importance of early diagnosis and intervention for spine-related problems?
Yeah, I would say early diagnosis is important, especially when there's neurologic compromise. But even more important than early diagnosis is getting the right diagnosis, because as Dr. Schroerlucke started in his first comments, it's you see back pain and it seems like it'd be a simple thing, but it's not. It takes a good history, a good physical, and then to take it a little bit further, getting the right diagnostic tools like an MRI or other advanced imaging, which is just one piece of the puzzle. It's not the full answer. And until you really hone in on the right diagnosis, what specifically is the cause of the pain, you can't begin to embark on the right treatment, whether it be this physical therapy modality. And we've got excellent physical therapists that can really give specific exercises. It's not just, oh, go to therapy and you'll get this general recipe. We try to be very tailored in all aspects of care, and it comes down to getting the right level on the right side on an epidural injection or whatever there's more than just one epidural type of block that we can administer, and then the same applies to choosing the correct surgery, which is a whole other nuanced approach. And so I'd say, yeah, early diagnosis, but getting the right diagnosis. So when that first initial encounter, taking the history exam, ordering the appropriate tests, and then going from there.
All right, we're getting some really good questions. This is a little bit of a long one. This viewer sent the question and then added a little bit more detail. So give me 1 second and I'll read it to you. Are you currently using any lumbar fusion alternatives such as Aurora Zip or any related procedures? And this person followed up. They've had an MRI and have been diagnosed with spinal stenosis and intrusions that are causing pain in L3 and L4. He's looking for alternatives to fusion and laminectomy.
You want to take that, Jason?
Yeah, in my practice, fusion is kind of the last option. It's the biggest surgery that we'd offer. You know, if we're talking about unilateral disease, L3, L4, or I'm sorry, one level disease, L3, L4, kind of that's the big operation, and that's kind of what we reserve as a last resort. I try to see if we can get by with a simple decompression. There's some other procedures out on the market, and yes, all of those things are on the table. A lot of my partners are the same way, but I try to start with the absolute conservative things first, like anti-inflammatories, physical therapy, injection therapy, and not until those things kind of fail do we go on to talking about surgical options. I will say, though, that sometimes fusion is the correct answer. If we don't feel like we're going to adequately tackle the problem with a simple decompression and it's going to lead to further problems and not address the pain, we don't want to do an unnecessary surgery where we're bouncing right back into the operating room or people are unhappy. So when we make the decision to go cut, we want to make sure we're doing the right procedure. So it's about putting everything together. Again, the history is the most important thing, and then we use the imaging as an adjunct, and come up with the right strategy.
Yeah, and I think too, with regards to like the Aurora Zip and some other, treatment options, I think there's a lot of things that have come and gone in spine surgery over the last, 20, 30, 40 years that we thought was going to be like the end all new thing for us, like lumbar disc replacements, which we do when it's necessary. Cervical disc replacements are really good options for some people, but we found some other things that we thought were going to be great that haven't turned out to be the best in the long run. And so I think that we are pretty conservative in that, or I'll speak for myself. I'm pretty conservative about newer technology and waiting for this technology to play itself out over 5-10 years before we start instituting it into our practice, because within orthopedics especially, I mean, we've seen so many implants that have come and gone that people start using them and using them, and then they're taking them out and taking them out and taking them out. So we are pretty conservative with different types of newer technology and making sure that we're doing the technology that's been tested for years, so we know the long-term results of those procedures.
How do you understand the studies showing that people with the same degree of scoliosis differ greatly in how much pain they experience, with many folks who have scoliosis experiencing no pain?
Yeah, I'll answer this real quickly. So I think first of all, you got to distinguish what type of scoliosis we're talking about, and this is where spine surgery gets kind of crazy. Is this a kid? Is it like a 10-year-old with scoliosis, or is it an 18-year-old scoliosis, or is it a 65-year-old with scoliosis? And they're very different. They're very different reasons why those three different people have scoliosis. Typically, we think that kids that have scoliosis don't usually have a lot of pain. It can have pain, but they don't have to have pain. However, adults that get scoliosis as they're older, their scoliosis is related to their disc degenerating and degenerative process in general throughout their spine. So they're going to be more likely to have pain. Now, whether somebody has a 25-degree curve and they're 65 years old, and another person has a 25-degree curve and they're 65 years old, why one person hurts more than another one is almost impossible to predict that. Like I tell patients all the time, I say, look, if we put your x-rays and MRI scan at a meeting with 100 spine surgeons and ask them what your symptoms are, none of them are going to get it right. Like everybody's symptoms are so different. And that's just another one of the most complicated things about spine surgery. That's why when Dr. Weaver was saying, the MRI scan is not the only diagnostic tool. It's not the only thing that we have at our disposal to figure out what to do for people. And your question is an incredible question, because there really is not a great answer. It could be, what their posture is like. It could be how much the nerves are compressed. It could be, how much inflammation they have in their body. It could be also what kind of other medical problems they have, what kind of medicines did they take. There's just so many factors involved to this, and it is an individual case-by-case basis. And that's why when somebody comes in with an x-ray, we don't just look at the x-ray and start telling the patient what we need to do for them, because we need to find out what their problems are.
And I would add to that, we need to know a lot more about the patient. So some people they've always been athletic, they've always stretched, they've always strengthened, they've always had really good core strength. And they don't have osteoporosis, they don't have osteopenia, their vitamin D levels are good. And then there are other folks who they may have been athletes when they were young or been more active when they're young, but now their activity is their work. Well, I walk a lot at work. That's a different person. And so even though the two people may be 60, 65 with a 25-degree curve or 30-degree curve or whatever, 8 times to 9 times out of 10, the physical examination is going to be different on those two people, and the history is going to be different on those two people. And that, to a large degree, dictates what we're going to see and what the advice we're going to give the person is going to be.
Okay. Does OrthoSouth provide any peptide and or hormone therapy or plasma replacement therapy?
I was going to leave that for Judy.
Yeah, so at this point, we do not provide hormone replacement therapy, plasma replacement therapy. So, things like, growth factors, PRP, orthobiologics, we do. And again, that a person will need to be evaluated for, and I think we do a great evaluation for that, talking about the potential benefits and, and risks of those things. And is it that, or is it bone marrow that we want to use? Is it, is it something else that we would want to use that is an orthobiologic treatment? Yes, we do provide that.
Okay, what are some of the latest advancements or techniques in spine treatment that you're excited about?
Jason, you want to go?
Yeah, I think one of the things I'm excited about is artificial disc replacement, specifically for the cervical spine motion preservation surgery. We alluded to this a little bit earlier. At least in my practice, I'm kind of looking for the ideal candidate for that. It's not something for everybody, especially as we get older and our spines are a little bit more degenerative. But I think that's one advancement that in the next decade or so, we're going to see it utilized a lot more. And the data is very compelling, specifically when it comes to the cervical spine.
Yeah, I think that is really, I think disc replacements are definitely coming along, and we got a lot of ways to go, but we're doing really well with that for sure. I think the other thing would be, the use of robotics in spine surgery, and being able to use robotics to help us make smaller incisions, do more complicated things, with the use of the robotics, which can help with preoperative planning and other things. The other thing is the stem cell things like they were just talking about a minute ago. If we could figure out how to stop these discs from degenerating at an early, like if we see degeneration and try to figure out a way to stop that, we could stop so many people's problems, and people could do so much better. Just like we do in knee replacement, hip replacements. Like we still haven't been able to figure that out, but I'm thinking one of these days we're going to figure that out.
I think those things are really exciting for me. The PRP, the plasma, the bone marrow aspirate. And I think the other thing that I think is really exciting is some of the more minimally invasive techniques that are developing and the equipment that we can now use. Like, for instance, for ablative procedures, the equipment I was using 10, 15 plus years ago and the equipment that I'm using now, completely different. The same thing with regard to spinal column stimulation. The artificial intelligence as it relates to that is really, it really takes things to another level in terms of what you can do for a patient and how you can see, things being programmed and their pain go away right before your eyes, like right there while you're in the office. So I think that the more minimally invasive techniques, the orthobiologics are important. And then my further excitement will be when insurance kind of catches up to some of those things.
And I think too, like you're talking about the minimally invasive things. I think Dr. Weaver's on the front edge of this, and that's like very, complicated surgeries that used to take people in the hospital for a week. Especially Dr. Weaver, he's doing them outpatient now. I mean, being able to do outpatient complicated lumbar spinal surgeries with smaller incisions is really exciting for our patients.
Okay, now I have a question for you. Could y'all speak about spinal cord stimulation? I know working with you all, that's something I hear a lot about, and I think that would be something great for our audience to hear from you. Could you who is an ideal patient for spinal cord stimulation? What does it take to get to that point? Whatever y'all can share to educate our audience on that.
Okay. Well, insurance regulation has changed things to some degree. Initially, it was someone who failed conservative care. Surgery was not appropriate for either medical reasons, meaning they couldn't be cleared for surgery, or the person didn't want surgery. A spinal column stimulator trial could occur with an implant if it was successful. Now it is something that can be offered when people have failed surgery. They continue to have back and leg pain or back or leg pain. If you have diabetic neuropathy, spinal column stimulation is an indication for that. And now there are also peripherals, so you don't have to have necessarily laminectomy to put it in permanently. And that's a case-by-case basis, depending on who the person is. So it certainly isn't something you do as a first-line treatment, and it's not something one does as a second-line treatment. It is something that is done when other reasonable care has failed, and the patient, the surgeon, and if it's my case and I'm doing the trial, we all agree that that's the next appropriate step for the person. The person has to undergo a psychological evaluation prior to, and the person has to have additional imaging studies prior to, blood work prior to. So there's several steps that have to be taken.
I think the thing about spinal cord stimulation that I like about it so much is that there is a trial for it, and that you get to trial your potential operation, which is not the case with any other surgery. You don't get to trial your gallbladder be taken out; you just have to take it out. But spinal cord stimulator, there's a trial for it, and so if people get to that point, like Dr. Sigler was saying, you can have the trial without having to go through the whole thing necessarily. If the trial doesn't work and you don't get the relief you want, then you don't have the permanent procedure done.
Or you could switch to, different companies have different strengths with regard to spinal column stimulation. So that's the other thing that's true. Sometimes people will, like in the old days, all the spinal column stimulators felt like 10 units. It felt like an implanted 10 unit. Well, that's not the case anymore. So there are a lot of options, to discuss, and I tend to discuss those options, with patients, and then let them look at, a couple of companies and kind of talk to, and talk about it, and then decide, where they want to go.
How can a patient tell if they need a neuro or spine surgeon, and does that matter?
Well, we're all spine surgeons. Neuro or orthopedic surgeon, I think, is the question.
Yes, my bad.
Yeah, we're trained different, but we all have the same ability to assess, evaluate a patient, and then get them to the appropriate skill set. There are procedures that Dr. Schroerlucke does that I don't do, and he's said it before. He sent me patients. I, in reverse, have sent him patients when I think they're better suited to his skill set. So at the end of the day, I don't think it matters. That's the beauty of being in this type of system, where it's not only orthopedics, it's not only neurosurgery. There are some situations where there are tumors inside the dura, and I don't think Sam wants to tackle that. But as a neurosurgeon, I've trained in that. So I mean, there are specific instances where you might need a neurosurgeon, and the corollary to that is there are specific instances where I'm going to send you to Dr. Schroerlucke's skill set, where he, in his orthopedic training, got something that I didn't have. And that's like I said, that's the beauty of conferencing with each other and knowing the different skill sets.
Yeah, I think it used to be like 20, 30 years ago, there was very different. The orthopedic spine surgeons and neurosurgeons were very different and had very different skill sets. But then everybody started training on, the same type of things then. And so now when you meet somebody who's an orthopedic spine surgeon or a neurosurgeon, everybody can instrument the spine, everybody can decompress the spine, but there are subtle differences that, we are well aware of. And if the problem is if you don't have a neurosurgeon to refer to, or if you don't have an orthopedic surgeon to refer to, you might be doing surgeries that is not like straight in your strike zone, And as a patient, I want my surgeon doing whatever's in their exact strike zone, exactly what they're really good at. And I think that there are some orthopedic surgeons that don't do what I do, and there's a bunch of neurosurgeons that don't do what Dr. Weaver does. I mean, everybody's just different. And so, it's hard to say what you need one or the other in any particular circumstance, unless you have a tumor inside your spinal cord, then you want to see Dr. Weaver.
Thank you, doctors. All right, how do you address the concerns about recovery time or the impact of spine treatment on daily life?
So I'll start just from a conservative standpoint. So generally speaking, I try to talk about and get to know what the person's daily life is in the first place. And then from there, try to steer them towards what we're doing now, how this is going to impact this that you do at work, this that you do at home. Do you need a sit-stand desk? Do you need, what types of things are going to make you more successful? And then in terms of trying to prepare a person, if I think a person's going to require surgery, we kind of talk about, the surgeon's going to talk with you about what they're going to need. And you need to be thinking about what your life is like so that you can ask the questions, have your clear questions ready for that surgeon in terms of how long you'll need to be off. Will you need, special accommodations, those sorts of things. And, I think we try to do a really good job of trying to prepare a person for the prior to, so that everybody doesn't need surgery, but the prior to, the things that they're going to need, and then trying to get the person organized in a way so that when they go to the surgeon, they know what to ask the surgeon in terms of how it's going to impact their work and their home life.
Yeah, I think one aspect in postoperative care that is misunderstood a little bit is how your family life is, like who you have to help you at home. So if you do have surgery, do you have a spouse at home that can help you, or do you have a spouse at home that you are helping them more often, And I have patients that, if I'm doing surgery on a 200-pound man and his wife weighs 95 pounds, she's going to have a tough time helping him depending on what type of surgery he has and how much problems he's having before. Whereas if the situation was reversed, he could probably help her, do more things. So some of that a lot of it matters about your home life and who's there to help you at home.
Thank you, doctors. All right, what are some common misconceptions patients have about spine surgery versus non-surgical treatment options?
I'll go ahead, Jake. Go ahead.
All right. Well, I hear. I guess to best answer this, I'll say there's two extremes. There's the ones that'll say, "Man, I've heard never have spine surgery, never do it," and then the other extreme is, "I just want the surgery, I want the surgery." Well, what surgery is that? There's no quick fix, and so on those two extremes, really the truth lies in that whole spectrum and the nuance of coming up with the best treatment plan. And so that patient that says never have spine surgery, well, sometimes surgery is absolutely necessary to get you better. If you got a big disc that you've tried everything under the sun and that disc is hammering that nerve, we want to get that disc off that nerve. And the reality is, yeah, we want to avoid some surgery when it's necessary, and we all hear the horror stories, but 95% of the time, or maybe even greater than that, people do excellent. They don't need any further surgeries in the future, and it's a one and done thing, and that's what we're striving for. And as long as the indications are solid, then we're gonna do what's best and get people back on their feet as fast as possible. On the other spectrum is the myth, like, oh, you just got to cut me, and my back pain's going to go all away. Well, there's a lot of times when that's not the solution either, and we don't have a surgery to offer for this. Now, there's a lot of other things that we can do, and that's the nuance that we were in, the complexity that we were kind of alluding to earlier.
Yeah, I totally agree. I mean, the two extremes are the most common thing we see, and I mean, I think Dr. Weaver would agree that, you know, we're probably trying to talk people out of spine surgery at first more than we would ever talk people into spine surgery, because people hurt really badly and people want to get better quickly, and totally get that. That makes perfect sense. But the problem is sometimes surgery isn't the right answer. Maybe never, but sometimes maybe not just right now. Like we think, hey, we got a chance to get you better without surgery. Let's try to do that. And so when people, you know, come to be, you know, I just need surgery now. I've got a problem. I'm a, you know, like people tell me a lot. They're like, hey, I fix things for a living. Like, let's just fix this thing, you know, and I get it. But sometimes, you know, it is a little more complicated doing spine surgery because there are complications, and they're rare, but we got to always keep them in mind. And so, you know, I would say we're probably talking people out of spine surgery more often than we are doing the other way around, for those reasons.
Thank you, doctors. I know we quickly touched on advancements in techniques and whatnot for spinal surgery and conservative treatment options, but I think, Dr. Lee-Sigler, I heard you mention AI. What are some up-and-coming applications of AI that we might see in back and neck care within the next few years?
Well, just speaking from my perspective, what I see right now is predominantly with spinal column stimulation. So, for instance, if a person comes in and they have a spinal column stimulator implanted, and the pain is, for instance, so basically the AI can monitor. The AI can tell, it knows what the settings are. The person can be messaged. Changes can be made without the person making those changes, and the person can be communicated with without a phone call or a text or anything, to get that right. And tons of, so many programs can be chosen from using the AI, and that program can be run, and then the person can, and then it'll be able to determine or help the person determine whether or not that's a good setting. And then the text that you get back, or the text that I'll get back, will say X number of programs, this is what was changed. The person is now running this program, and the person is getting 80% relief with this, and 90% relief with this, and then I know, from there, what to expect when I see that person back. I know how I'm going to, manage things. And all of that happens in just a few minutes. And so what I expect is all of that's just going to get faster, and faster, and faster. And then the communication can come back on my phone, as opposed to me having to log on to anything. So it's really good. Sometimes, you're logged on, but the program is just running. So I think I'm excited about that. I'm excited to see how AI helps with electrodiagnostics, because I think that's gonna turn out to be something that's really important. And I'm excited to see how that's going to help with radiofrequency ablative procedures. I just think there is I have a ton of excitement for it. And I think that a lot of it has to do with being able to, sometimes it's hard for people to communicate as quickly as they'd like to and as efficiently as they would like to. And I think that this is going to really help that process along. So from a non-surgical standpoint, those are the areas that I can see just right off the bat that are going to turn out to be really helpful.
Yeah,
All right.
I'll just add that one thing that's exciting to me is outcome data
Yeah.
How patients do across vast populations, and there's registries across the country that are tracking these things, and then to be able to mine that data through AI will help guide treatment. I think it could be a double-edged sword. I'm concerned that some of the things and the nuances that we've talked about, and if you, lack of a better term, the art of medicine might be taken out of the provider's hand a little bit. But at the same time, being able to mine data on vast scales to help patients find the best treatment algorithms is very quickly coming, and insurance companies are in tune to that, and we as physicians are going to use those tools. I hope we don't lose some of that art along the way.
All right, and we've been through all of our questions. So as we wrap up, I would like to ask, is there anything we didn't cover tonight that you think prospective patients should know?
From my standpoint, and I think many patients know this, but I think it's really important if a person is coming to have, if they have outside imaging, if they have, you have to have your medication records when you come. You need to bring, if you are able to bring records, that's great, or make sure that they're sent. I think if you have imaging, this outside imaging, we can upload that quickly. But I think, but I think those kinds of things turn out to make the appointment much smoother if you have them. And one of the most simple things is just knowing what your medications are. I think that it sounds like a thing that everyone would do, but it really doesn't happen as often as one would like. And then just being sure that if there are records that we need to have, we have them. Now, we're happy to help you. If you don't have them, you still come to your appointment, because we'll have you sign paperwork and we'll get it, we'll get it for you. But it does make things faster. It kind of streamlines things for us.
Yeah, I think one thing maybe in terms of just the spine in general is that when you have a spine problem, a lot of times it takes us a little bit to figure it out and to figure out what the right answer is. And what we don't want to do is rush into something and us be wrong, and then now you're dealing with a surgery that didn't help you. And so sometimes I think people get a little frustrated because we're trying this injection or trying that physical therapy or trying that medication or getting this extra MRI or this EMG or this CT scan. But it's all for the benefit of making sure that we're doing the right thing for this particular diagnosis in this particular patient. And so I think, we're all after the same thing when people come to the office, and that's to get the patient better. And but sometimes it can be a little more challenging than if you have knee arthritis and you go see one of my partners who does knee replacements. I'm not diminishing that, but it's a little bit simpler sometimes.
Mm-hmm. Okay.
All righty. Well, thank you all for joining us tonight. Doctors, thank you for providing your expertise on this variety of questions. You were greatly appreciated. We will have this recording available on our website and all of our social platforms over the next couple of days. And if you have any additional questions, again, please feel free to email us at os-marketing@orthosouth.org. I hope everyone has a good evening.
Thank you.
Thank you,
guys.
everybody.
Thanks.